So reviewing from last class, we kind of reintroduced the concept of the elastic recoil model. And the respiratory system, obviously with the lungs and the chest wall, the lungs in particular being an elastic structure. When they expand, they want to recoil. And so we have to have an appreciation if we're ultimately going to get to the point of understanding what are the determinants of the work and the oxygen cost of breathing, and how might, in the extreme kind of health, as well as in disease, how might the respiratory system impose a limitation on, say, peripheral muscle blood flow, or contribute to an inability to exercise. We have to have an appreciation for the determinants of the work of breathing. So we're going to set further foundational kind of understanding today about the resistant and the elastic work of breathing, and then we're going to deviate away from it a little bit for a couple lectures. We're going to come back to it, okay? When we start talking about work of breathings, experimental manipulations to it, with simultaneous measurements of blood flow and exercise capacity and stuff. Right now we're just setting a little bit of a foundation of the work of breathing. So we talked about, in accordance with Hooke's law, is that as an elastic structure stretches, its compliance decreases. So over some range of the balloon's inflation, you can see that we get relatively large changes in balloon volume for relatively small changes in distending pressure. So if the work of breathing is basically how much pressure or force does the respiratory system or muscles need to generate in order to create expansion of the volume within the balloon, in this case the lungs, that ends up becoming a very efficient system. So we can minimize the work of breathing by decreasing the amount of pressure that needs to be generated by the inspiratory pump muscles to achieve a given volume. Now, if you were just thinking about where along this curve you would want to breathe, would you want to breathe up here at this flat A linear portion of the curve where you have to do a lot of work to get very little reward? No. You know, for example, you wouldn't want to study 20 hours and walk out and get 10% on the exam, right? That is a bad investment of time. You would like to study 1 hour and get 100%. So in the end of it all, you want to basically have the least investment of time and energy for the maximum amount of reward. So in that particular case, you would want to breathe along this linear portion of the curve, where the relationship between the pressure developed by the respiratory muscles and the volume expansion would be more in favor of volume expansion relative to, or more in favor of breathing muscle function, so to speak. So, less pressure for a given volume. We also talked about airway resistance, and so much like muscle blood flow, is that the resistance to airflow is determined in large part by the regulation of bronchomotor tone. So the airway smooth muscle itself has a tone. It's under the influence of parasympathetic modulation as well as some sympathetic modulation. And so you can have a circumstance where the airways can constrict or they can dilate. So pharmacologically, you can give an anticholinergic bronchodilator, a beta-2 agonist, and what will happen is that the airway smooth muscle will relax, and that will cause the airway radius to increase. And because airway radius is raised to the 4th power, we know that decreasing airway radius by 50% will result in a 16-fold increase in airway resistance, or a 16-fold decrease in airway conductance. So the point is that small changes in airway diameter and radius have dramatic changes in airway resistance. Airway resistance, in turn, dictates the amount of pressure the respiratory muscles need to generate in order, again, very key, to move a given amount of air into and out of the lungs. We have to examine kind of the work of breathing in relation to how much we're actually breathing. So, if Evan is breathing 50 liters a minute and I'm breathing 25 liters a minute, and his work of breathing is 200 joules and mine is 100 joules, well, the difference in the work of breathing is proportional to the fact it's twice the work of breathing for twice the amount of ventilation. Now, if it was 200 joules and 100 joules, and we were both breathing 50 liters a minute, now there's a problem. Because now somebody's doing twice the amount of work to generate the same amount of air flowing into and out of the lungs. So it's key to have an evaluation at a given rate of airflow into and out of the lungs. Changing in airway resistance will dictate the amount of pressure that the inspiratory pump muscles have to generate to create that pressure gradient to move air into and out of the lungs. So greater resistance, greater pressure. Lower resistance, less pressure. Greater resistance, greater pressure, greater work and oxygen cost of breathing. Less resistance, less pressure, less work, less oxygen cost. Extend that out, potentially less competition between the respiratory muscles and the peripheral muscles. Think about adding arm exercise to leg exercise when we did that last net drive hypothesis example. It has the potential to steal blood away from the limb muscles, particularly if they're accepting so much of a cardiac output that's limited. So we'll get to that. But that's where I kind of want your minds to start thinking. If we didn't have mechanisms to try to regulate bronchomotor tone during exercise, and the airway is just constricted, we would have to generate massive work of breathing. If we didn't breathe in a particular way, the work of breathing would be elevated, and that has the potential to start stripping blood away from the limbs. Fortunately, in health, our breathing is really functioned or designed to stay on that linear portion of that compliance curve, and I'll show you that. So, airway resistance is a major determinant of the pressure that needs to be generated to move air into and out of the lungs. So we talked about this in the context of bronchoconstriction. An increase in airway resistance necessitates an increase in the driving pressure for airflow or the work of breathing to support a given amount of rate of movement of air into and out of the lungs. If you do the opposite, if you dilate the airways to maintain the same in the setting of a reduced airway resistance or an increase in airway conductance, you can maintain the same rate of airflow into and out of the lungs by getting away with less need to generate respiratory pressure. And therefore you have a lower work and oxygen cost of breathing. So, that is a recap from the last class, or the end of the last class. Now we start getting into the relationship between breathing mechanics and airway resistance. Okay? So, if we look at the relationship between airway resistance and lung volume, here we're going from basically at 0, 0, this is the lungs completely empty, say to the lungs completely full. Sorry, the lungs are completely empty to the lungs are completely full. And this is very, very low resistance, so this is as if the airways are completely dilated, and this is as if the airways are completely puckered shut. Okay? So what you see is that as lung volume increases, you actually see this kind of nice curvilinear decline in airway resistance. So, it basically says that if you breathe at low lung volumes, you breathe with a high airway resistance. If you breathe at high lung volumes, you breathe with a low airway resistance. Now, why is this? So, in our lungs are basically, our airways are tethered to the lung parenchyma, which are like little elastic bands or structures. So when our lungs expand and the parenchyma stretch, they basically have a tethering effect on the airways. Okay, so imagine for example, this is an airway, okay? And then you have these parenchymal attachments, like these little springs that attach to each of the airways. So when your lungs stretch, these parenchymal attachments will begin to pull outwards, which will pull the airway open, which will increase the airway radius, which will decrease the airway resistance by a factor raised to the power of 4. So, when you breathe in, your airways are literally connected to the lung tissue being stretched open mechanically. So at high lung volume, you have very low airway resistance because the airways are tethered open. As you begin to blow out, though, you lose that tethering effect, and now the airways begin to narrow. And so as you begin to blow all the way out to your residual volume, when you begin to breathe all the way into your residual volume, is that your airways basically become very kind of like puckered and tight, where the resistance becomes very high. So, I want you to think about the elastic recoil model here. So it's kind of a weird circumstance. Breathing at a high lung volume dilates the airways, but breathing at a high lung volume does what to the inspiratory elastic recoil? So take a breath into your lungs are full. That's a high lung volume. So is the lung trying to recoil? Yeah. Yes. But at that high lung volume, are the airways more dilated or less dilated? That sucks, eh? So you get a lot of elastic recoil when the airways are dilated. This has implications for the way we try to breathe. If we get into a circumstance where we become limited by airflow, and this is a blanket statement right now, but if we become flow limited, we have a limitation in our ability to move air in and out of the lungs, we actually will kind of for reasons that we don't completely understand, we will begin to breathe at a higher lung volume to try to take advantage of that mechanical stretching effect to minimize airway resistance. But when the mechanism is to breathe at a higher lung volume, while you decrease airway resistance, it comes at the effect of increasing the elastic recoil. So you basically shake the hand on one side, you get kicked in the butt on the other. But again, it's a balance of factors. Which one is more beneficial? Okay? You can modify your breathing pattern to prevent excessive changes in the work of breathing. There's various things that you can do. But what I want you to be cognizant of is that breathing at a high lung volume will decrease airway resistance, but it will increase the elastic work imposed on the inspiratory muscles. Okay? I say this now as a precursor because it will become important in understanding in this class, but also in exercise patho when we talk about COPD and asthma, why the work of breathing is so elevated and why the body does certain things that it does in the context of exercise. Okay? So, at residual volume, so basically, anybody know residual volume, kind of a concept, what it is? It's the volume of air at the very end of an expiration. So right now I want everybody, just so we can anchor it for those that are kind of doers and not seers, I want everybody to take a breath into your full and blow all the way out till your lungs are completely empty, until you absolutely can't blow out anymore. That's residual volume. All right? Now, that's total lung capacity. Okay? So completely empty to completely full. From when you're completely empty to when you're completely full, that's also what they call your vital capacity. We'll talk about that. We'll show that on a spirogram. But just to give you a sense. Okay? So at residual volume, this is a cross-section of an airway at residual volume. You can see how narrow it is. At total lung capacity, it's stretched. So the radius is dramatically different, explaining this curvilinear relationship. At TLC, airway resistance is negligible. At residual volume, airway resistance is very high. So again, you can already get an appreciation that, okay, we would want to breathe at a lung volume where the lung is compliant, it's not stiff, but we also want to breathe at a lung volume where the resistance is not particularly high. So I'll show you this where we breathe, but airway resistance decreases as lung volume increases because airways distend as the lungs inflate, and a bigger airway has lower resistance or greater conductance. Okay? So this comes back again to Poiseuille's law that we showed previously about the airflow. So how do we measure this? This is from years ago. And we do this in the lab all the time. You can put a balloon down into basically into their esophagus. So in my lab, we do this quite often. We actually have a pretty unique catheter, the only lab in Quebec and one of only 3 in Canada and one about 10 in the world. But it's a catheter that on a single catheter has a balloon that goes into the stomach. And then it has a balloon that sits in the esophagus, and between those two balloons has EMG electrodes. So it gets positioned at the crust of the diaphragm, and so we can actually measure the motor unit recruitment of the crust of the diaphragm. We can measure all the respiratory muscle pressures generation in the esophagus, so the intrapulmonary pressure. We can measure the gastric pressure, which is the pressure generated by the abdominal muscles. And then by subtracting the gastric pressure and the esophageal pressure, we can measure the pressure that the diaphragm creates. So we can measure expiratory muscle pressure, inspiratory muscle pressure, diaphragm muscle pressure, and the brain signal to the diaphragm to contract. So pretty unique. So what we can do now is we can say, okay, for this amount of neural input, what's the pressure generation? What does it translate into flow? And then how does that flow and volume translate into symptoms of breathlessness? So we can basically look at the series of events from the neural activation of the muscle to its pressure generation to the flow that it generates in terms of tidal volume, and then associate all these things in terms of exercise capacity, drug interventions to try to dilate or restrict the airways, and really understand from a mechanistic perspective why somebody feels short of breath. And then so once we understand the mechanism, we can really begin to target treatments to try to affect certain pathophysiological parameters. So this is tangential to the point. The point is here is that if you push a balloon about 50 centimeters down into your body, you can put a balloon into the esophagus and you can measure pressure swings generated by the respiratory muscles. So on inspiration, esophageal pressure goes down. On expiration, esophageal pressure goes up. Just like we talked about moving along the pressure gradients relative to atmosphere. So you freeze both nostrils with some lidocaine. You freeze the back of the throat to eliminate the gag reflex. Put a little bit of gel onto the balloon and shove it in. Get somebody to sip some water and you just swallow the catheter down. You do some sniff maneuvers to make sure it's in a good position. You tape it to the nose and that's it. And then you breathe. So she's obviously having much more fun than I am putting it in. Once it's in, it's fine for most people. But so this is how we measure breathing mechanics, statically and dynamically. We have to measure volume. So we measure volume through a pneumotac. It measures the rate of airflow, and then the change in airflow over time, it gets integrated and gives you a volume. And then we can also measure the simultaneous changes in pressure with the balloon that's down in the esophagus. So we can relate pressure changes to volume and create that pressure volume curve. Look at lung compliance or respiratory system compliance. Right? So if we do that, if we look at the relationship between lung volume and respiratory pressure, so this is an indication of how much, again, this is an indication of the force of contraction of the respiratory muscles, and this is the volume that they generate. Okay? So, the pressure volume curve of the respiratory system looks a lot like the sigmoid curve of the oxyhemoglobin dissociation curve. It's an S shape or a sigmoid curve that has a linear portion of the curve, so this linear component of the curve, and what we call the upper A linear and lower A linear extremes of the curve. Okay? So, without going into it, where's the most compliant portion of this curve? Is this a compliant portion of the curve? Here? No. So if you were to breathe, if you were to place a breath on this curve, where would you want it to be?
The linear.
You'd want to breathe ideally along that linear portion of the curve, where the respiratory muscles don't have to generate much pressure to expand volume. That would be the most efficient system. Now, if that's where you breathe, you would also want to adopt a breathing strategy where you avoided breathing all the way down here, and you avoided breathing all the way up here, right? Because even if you went from breathing here at rest, but then say during exercise you started to breathe very close to total lung capacity, that might be disadvantageous. So we would want to have a control mechanism or a physiological support system that would allow breathing to change along that linear portion of the curve. So to allow ventilation to go up while simultaneously minimizing the work in the oxygen cost of breathing. Okay? So, down here at residual volume, again, you see that you would have to generate relatively large pressures to get relatively small volumes. So, what's the relationship between airway resistance and lung volume? Airway resistance is what at residual volume, high or low?
High.
It's high. So, to move a given amount of air into and out of the lungs in the setting of high airway resistance, the respiratory muscles have to generate more or less pressure? More. So breathing at a low lung volume when there's high airway resistance basically makes the respiratory system non-compliant. Because you have to generate big pressures to overcome the lung volume related flow, airflow resistance, to generate a very small lung volume, tidal volume. So, to the extent possible, you'd like to avoid breathing at low lung volumes. In obesity, this is where individuals breathe. They breathe near residual volume. Actually, it's kind of embarrassing, but also, a year ago, at the end of January, I weighed 270 pounds. Yesterday, I was 208. I dropped my body fat percentage from 40% yesterday to 18.5. But that's not the point is that I have lung function tests from last year where I was categorized as obese, and this year when I wouldn't be. And I can show you the impact of obesity on where you breathe in relation to a flow volume loop. I'll try to bring that up because it's actually pretty striking. When I was bigger, I breathed all the way down here. Now that I'm not as big, I actually breathe up here, at rest. So just the loss of weight completely shifted where I breathe, even though my lung volumes and airflow capacity didn't change. It just shifted where I breathe in relation to my residual volume, my total lung capacity. So it's pretty striking to see it, particularly when you understand what you're looking at. When I first saw it, I was like, holy shit, couldn't believe it. It was like a textbook. It was pretty cool. So the idea is that breathing near residual volume, you have to generate a large change in pressure to elicit a relatively small change in volume. So it's the pressure-volume relationship is non-compliant at low lung volumes. This is basically the relationship between airway resistance and lung volume. At low lung volumes, you have to work against a high resistive work of breathing. Okay? So, little in-class experiment. Blow the air out of your lungs until you're just about empty, and then hold that lung volume and try to breathe down there. So, try to breathe down there. It's not particularly comfortable, is it? So you're working against that airflow resistance. Yeah, exactly. As soon as you can take a breath in, you do it. Because it sucks to breathe down there. Because your respiratory muscles are like, all of a sudden I'm doing a lot of work just to breathe normally. So remember, if you start doing more work, if you lift 10 pounds versus 50 pounds is perceived as much more work. If you have to breathe against the resistance, even in this simple example, it's perceived as more. You become more short of breath, greater respiratory discomfort. So to prevent everybody from walking around in the world being short of breath and uncomfortable, you try to avoid breathing at low lung volumes. Let's go to the opposite extreme. What happens if we breathe near... Yeah?
What makes an obese person or overweight person to breathe at high?
It's basically so this curve is generated by a balance of the recoil forces between the lung and the chest wall. So what happens is that, without going too much into it, when in obesity, what happens is that when you get a lot of fat around the rib cage and actually around the visceral organs, what happens is that it changes the compliance of both the lungs and the rib cage. So you have to have basically a greater inertial load to move a heavy chest wall, and the lungs themselves actually will kind of get pinched and impinged around with the subcutaneous fat and things like that. So what happens is that it's really just strictly a mechanical effect, where you get a stiffer rib cage and a stiffer lung, which will force you to breathe at a lower lung volume. It'll just it's more of a mechanical factor than it is anything else. We've done a study in bariatric surgery where if you lose a substantial amount of body mass over a 3-month period, you don't change your lung volumes and capacities, but you change where you breathe within. So again, and we've subsequently done a DEXA study where we looked at people with high thoracic fat mass versus low thoracic fat mass, and we found that if you have relatively more fat in the upper body compared to somebody with relatively less fat in the upper body, it just shifts where you breathe relative to your residual volume. So all of that to say, it's not necessarily pathology of the lung per se, it's just that the fat around the rib cage and the lungs make them stiffer, and that forces you to breathe lower. If you lost weight, they would relax, so to speak. Okay. So let's say that you breathe up here in your total lung capacity. The same thing. You have to generate big pressures to get relatively small volumes. And so now, you're breathing again on what they call the upper alinear extreme of the curve, or again, a non-compliant portion of the curve. And this is when, and this is very important, I want you to be very specific when you're describing this in the exams. Okay? And in written answers or even on multiple choice questions. If I said to you, breathing, when your end inspiratory lung volume encroaches, so this might be a question, for example. When end inspiratory lung volume encroaches on total lung capacity, the following work of breathing increases. The inspiratory elastic work of breathing, the expiratory elastic work of breathing, the inspiratory resistive work of breathing, the expiratory resistive work of breathing. One of them is more correct than another. It's going to be the inspiratory elastic work, because at high lung volumes you have an elastic recoil, and to breathe in, the inspiratory muscles have to work against that elastic recoil. So in that case, it's an inspiratory elastic work of breathing associated with breathing at a high lung volume. Okay? So I want you to be able to have an appreciation that it's an elevated inspiratory elastic work. So basically here we're looking at, we're applying now Hooke's law. Whereas the lungs distend, the recoil increases, we have to generate more pressure to get a given volume. So, I want you to do the opposite. Everybody take a breath in so your lungs are full. Hold your breath and try to breathe there for about 10 seconds. See what that feels like. Sucks too, right? Yeah. So that's your respiratory muscles have to do a lot of work to overcome that stiff chest wall and the lungs that's trying to recoil. Now, as you'll see in exercise patho, probably beaten to death, is that patients with chronic lung disease breathe at these lung volumes reflexically. Their pathophysiology forces them chronically to breathe at high lung volumes. So, getting up here to room 403 or whatever it is, you walk up a couple of flights of stairs, you might notice that your breathing goes up. Not a big deal. You don't have to slow down, you don't have to stop. Not everybody. It worked out perfectly, eh? You see how that worked out? It worked out perfectly. So then, but if somebody with chronic lung disease, severe emphysema or bronchitis, 5 steps up the first flight of stairs, they often have to stop, bend over, catch their breath, because what happens is that their airway pathology and their lung pathology will force them very, very quickly to breathe like you just did for 5 seconds. The difference is they have to stop exercising for them to allow them to decrease their lung volume. Otherwise, their breathing is too accelerated. As you'll see later on, they breathe in before they're done breathing out because their airways are very collapsible. And so the only way to prevent that from happening is to breathe longer out than you do in, to basically let the lung catch up. We'll talk about that in more detail later. But the idea is that where you're very fortunate that you can do this experiment and then just deflate and be like, oh yeah, that sucked for 5 seconds. This is what somebody with a smoking-related chronic obstructive lung disease breathes like all the time. And even when they're maximally medicated on short and long-acting beta-2 agonists and have all the anti-inflammatories and they're breathing oxygen, they still cannot escape. Then somebody like me comes in with research and I try to give people morphine and stuff like that, because if they've optimally medicated but they still feel like crap, you got to give them something. So we're trying to find new stuff to give them. Matt?
Yes, I'm curious to know, like, as a kid, if you're training one of those people, is it safe to push them, and like, do you want to like increase their tolerance?
Yeah.
Does that work?
Yeah. So, I mean, we'll talk about it more, obviously, for those that are going to be in class next semester, but there's such a psychopathology as well associated with chronic disease, like fear and foreboding, anxiety, breathlessness triggers. So people stop well before they reach a physiological maximum in terms of their heart rate and stuff. Ironically, the best medicine for somebody with a chronic lung disease is actually exercise. But the thing that makes them most uncomfortable is exercise. So they have to come to this appreciation that they have to exercise as hard as they can for as long as they can to get the biggest benefit. So the idea is that the idea of pulmonary rehabilitation or rehabilitative exercise training in chronic lung diseases is that you train the muscles to unload the lungs. You don't actually grow the lungs. The lungs don't get better in their function. Once they're done, they're done. And exercise is not a stimulus. But what you can do is you can decrease the stimulus to breathe by causing peripheral adaptations to the muscle. so that every step that you take up a stair doesn't require as much of a demand of oxygen consumption, as much of a need of heart rate, as much of a need of ventilation and gas exchange. So you can train the muscles to unburden the lungs, but you need to get a stimulus that's high enough to train the muscles. So to your point, yes, teaching them that, like anything, teaching them that breathlessness is, it's fearful, but that they'll learn to deal with it, and that sometimes dealing with some of that discomfort will allow them to achieve benefits, improve their quality of life, their functional status and capacity. But that becomes very fearful when you literally don't know if you're going to get another breath. Some of these participants in our lab, for example, they'll come in and they'll exercise, and we're like, as soon as you're ready to end, give us a wave, because we've got hundreds of thousands of dollars worth of equipment hooked up to these people, and they just get so fearful that breathing on a mouthpiece that they literally grab it from their mouth and they just rip it out of their mouth. And so just because they just need a breath, they can't have any encumbrance around, they just need to get a bigger breath. So it doesn't matter what we do, it's a reflex. If you're suffocating, think about that. If you're suffocating, as the suffocation sense gets greater and greater, you struggle more and more and more and more. If you could eliminate the suffocation, you would. And that's, in a way, that's what they're doing. They're pulling that form of impedance away from them. It's just too uncomfortable. But there are ways to try to, ameliorate that, to Matt's point, and get them to train at higher intensities. But again, that's tangential, but it gives you a little bit of application of how breathing at high lung volumes is so detrimental. So, this is where we would want to breathe. Fortunately, healthy individuals do breathe along this line. They do breathe along the compliant portion of the pressure volume curve, at rest as well as during exercise. And we'll talk about that. So here you generate big volumes for relatively small changes in pressure, and this is where both the resistive and the elastic work of breathing are minimized. Because it's high resistive work of breathing down here and it's high elastic work of breathing here. So by breathing along the linear portion of the pressure volume curve, we minimize both inspiratory elastic work of breathing as well as the resistive work of breathing. Okay? So that's basically a summary. So ideally we would like to breathe on this linear portion of the pressure volume curve. So this is quite a bit of context until what we'll do is that we're going to come back to this in subsequent lectures. We're going to go away from this, go into a little bit of gas exchange, alveolar ventilation. So why do we need to breathe in a particular way? Why do we want to breathe with a higher volume and a lower breathing frequency? To then come back to the mechanics of breathing. Okay? So, to give you a context, have you all seen in Physiology 209 or 210 a spirogram? So this is quite familiar to you, hopefully. So these are the subdivisions. We have lung volumes and capacities. Basically, as you'll see, capacity, what you'll see is that the capacity is basically a sum of more than one volume, and a volume is an individual measurement. Okay? So here's a basic spirogram. So here we have normal breathing. So here's a breath in and a breath out. A breath in and a breath out. A breath in and a breath out. At the end of a breath out, person takes a big breath into their full. They blow all the air out until they're completely empty, as you did earlier in the class, and then they go back to normal breathing. So just to try to anchor some of these nomenclature and terminology. The total lung capacity is basically the total volume of air in the lung, both functional and non-functional. So we have, it's the total lung volume including the residual volume. The residual volume is basically that volume of gas that gets trapped in the lung that you can't really use. In disease states, it's this residual volume that rises because the airways close prematurely. So you get what they call pulmonary gas trapping. So the residual volume is basically a way to look at it as trapped gas. It's gas that you can't necessarily use. Okay? Then you have your functional residual capacity, also referred to as your end expiratory lung volume. So, the name implies what it is. This is the lung volume at the end of a normal expiration. It's similar to, or the same as, the functional residual capacity. Okay? So the functional residual capacity is the sum of the residual volume and the expiratory reserve volume. So really what you have then is that from the difference between the end expiratory lung volume and the residual volume represents, as the name implies, the reserve that you have to blow a bigger breath out. You have its opposite, the inspiratory reserve volume. So now above you have the inspiratory reserve volume, which is the difference here between the lung volume at end inspiration, the name implies end inspiratory lung volume, and total lung capacity. So you can see that you have, in this particular example, a pretty big inspiratory reserve volume and a pretty big expiratory reserve volume. We'll translate ultimately this back onto pressure volume curves and flow volume curves. Our tidal volume is the difference between end inspiratory and end expiratory lung volume, and this is the volume of every normal breath. The tidal volume will increase with exercise, it will decrease with, say, sleep. Okay? The vital capacity is the volume of air from when our lungs are completely full, like we did earlier in the class, until our lungs are completely empty. So this represents, at least in healthy individuals, the maximum capacity to generate a tidal breath, right? It's not the tidal breath that we're taking now, but it's the tidal breath that we could take if every breath that we took was a maximum inspiration followed by a maximum expiration. So the vital capacity in healthy individuals sets the limits for tidal volume expansion. If your vital capacity is 4 liters, your maximum tidal volume is 4 liters. If your vital capacity is 2 liters, your maximum tidal volume is 2 liters. So, biological sex differences. Men are taller, lung volume varies in proportion to height. Men have a bigger vital capacity. They have a bigger capacity to generate a tidal volume. Normalize the body size, very similar. But because on average men are bigger and lung size varies with body height, men can generate bigger volumetric breaths. Okay? A very important measurement, particularly for next semester, but to some extent now, is what we call the inspiratory capacity. It's not probably a volume or capacity that you've heard a lot about, but you hear a lot about it from me. The inspiratory capacity is the volume of air from the end of a normal breath out to when your lungs are completely full. This is one of what we call the dynamic operating lung volumes, because during exercise, what you'll find is that through dynamic changes in end expiratory lung volume, you can actually get an increase or decrease in the inspiratory capacity. It's also this inspiratory capacity measurement in diseases like interstitial lung disease, severe asthma, chronic obstructive lung disease that actually will decline. And we know that this inspiratory capacity measurement is a good predictor of mortality, disability, breathlessness, exercise intolerance. So it becomes a very, very important but underappreciated measurement. And it's very easy to measure. At the end of a normal breath out, take a big breath into your full. Everybody, at the end of a breath out, big breath into your full. That's your inspiratory capacity. Super simple to measure. Much easier than putting somebody in an enclosed box and measuring the amount of gas trapping and all this different type of stuff. At the end of a normal breath out, take a big breath into your full. Do it 3 times, measurements are repeatable. Now you have your inspiratory capacity. So it's a pretty routine measurement, not measured all the time, but I think it has a lot of importance, particularly understanding clinical pathophysiology of lung diseases. So, here's our spirogram. Now, let's translate all of those volumes and capacities back onto the pressure volume curve. And then subsequently into a flow volume curve. Okay? So again, residual volume, as we showed before, is all the way down here when our lungs are completely empty. Total lung capacity up here when our lungs are completely full. This is our tidal volume breath. So here is a breath out on this arm of the curve. Here's a breath in. Our end inspiratory lung volume, our end expiratory lung volume, or functional residual capacity. The difference between the two is our tidal volume. The difference between end inspiratory lung volume and TLC is, as the name implies, the reserve for inspiration. the difference between residual volume and end expiratory lung volume is our reserve for expiration. So basically what it's saying is that if we were able to decrease the end expiratory lung volume lower and end inspiratory lung volume higher, we could expand tidal volume and stay on the linear portion of the curve, right? You can get a bigger breath, but you can still do it on the linear portion of the curve. So during exercise, healthy adults in particular take advantage of the fact that they have an expiratory reserve volume and an inspiratory reserve volume, because they will expand their tidal volume along this linear portion of the pressure volume curve, where the resistive and the elastic work of breathing is minimized, right? So having an appreciation for this is important. Again, the difference between end expiratory lung volume and total lung capacity is our inspiratory capacity, and from when our lungs are full until they're empty is our vital capacity. So go back, familiarize yourself with these lung volumes and capacities and what they represent and they mean. Now, you heard about spirometry. Spirometry basically is a measurement or an evaluation of how much air can you empty from your lungs in a period of time. Okay? So it gives us a measurement of flow volume characteristics. At any given lung volume, what's the maximum amount of airflow that you can generate? Okay? So if you come into the lab or you go to a lung function lab, what somebody will ask you to do is do a maximum forced expiratory and inspiratory maneuver. So you have a nose clip on, you're on a sensor that measures the rate of airflow into and out of the lung, and what you do is you breathe along normally. At the end of a normal breath out, you take a big breath into your full. As soon as your lungs are full, you blast out as hard and as fast and for as long as you possibly can. You keep blowing, you keep blowing, you keep blowing, and when your lungs are completely empty, big fast breath in again. So what you get is you get an indication of the maximum expiratory flow generating capacity across the lung volume from when you're full to you're empty, and the maximum inspiratory flow generating capacity from when you're completely empty to you're completely full. So you get an indication of kind of like the flow limits, the limits of the airways to move air into and out of the lungs quickly at any given lung volume from TLC to residual volume. It sets the limits for maximum breathing capacity, for lack of a better explanation. Okay? So we look at what we call the volume time plot. If we integrate flow over time, we get volume. Okay? So here you can see at 0, 0, this is when your lungs are basically completely full. Just to give you an indication, this is when your lungs are completely full. So in, as soon as your lungs are full, you're at 0.00. Because you're looking at the expired volume in relation to expired time. So you would have to be full, because you can't breathe out when you're empty. You're empty. Right? So at 0.00, you blast as hard as you possibly can. Now, at total lung capacity, airway resistance is high or low? Commit to it. Good. Low. So, if airway resistance is low, airway conductance is high, you can you can move a lot of air very quickly, right? Now, I keep emptying. My lung volume is doing what? It's decreasing. What's happening to my airways? It's restricting, exactly. They're compressing. They're constricting. So what's happening to the airflow? Basically the airway resistance is going up. So now I'm generating big effort, but I'm not getting much in the way of a change in volume. So look at what the volume time plot looks like. At very high lung volumes at TLC, 0.00, on a forceful expiration, you can get a huge amount of air out in a very, very short period of time. But as you begin to empty, and those airways begin to close, and the airway resistance increases because of that loss of the mechanical tethering effect, volume begins to decrease in terms of its rate of change, and it takes you longer or more effort to move less air. we'll translate this back into a flow volume curve subsequently. So what happens, to get a sense of the maximum breathing capacity, or the extent of airway obstruction, we can evaluate how much air do you expire in the first second of a maximum maneuver relative to the total volume of air that you expire in the maneuver. So what we look at is something that we call the FEV1, or the forced expiratory volume in 1 second, to forced vital capacity ratio. So it's the amount of time expired at a fixed period of time, 1 second, relative to the total volume expired. Now, this could take 6 seconds to complete. This could take, with patients with severe COPD, this can take sometimes 35, 40 seconds. Their face looks like it gets so red it looks like their head is going to explode. Because they're generating so much effort, but they're moving, they're just seeping air out of their lungs at such a tiny little rate. So you can imagine then that the higher this ratio, the closer this ratio is to 1, the better your lung function is. The less of an obstruction to airflow there is, because you can get most of the air out very, very quickly. Right? So if we look at the ratio between the forced expiratory volume in 1 second relative to the total vital capacity, we get an index of airways obstruction. And in any of us, if I brought you to the lab, the majority of you will be able to expire greater than 70% of your total vital capacity out in the first second. Now, if you were an asthmatic and I brought my dog in, and in half an hour you had an asthmatic attack, and then I put you onto the system again and measured a spirometry maneuver with your airways all constriction and twitchy and constricted, the FEV1 to FVC ratio would decline. Not because your vital capacity has gone from 10 liters to 5 liters, but because at any given lung volume, your airways are now more constricted. So you can't